Okay, so hello and welcome everyone. My name is Devjit. I'm doing my PhD at IIT Madras and I'm working on pulmonary fluid mechanics, trying to understand the evolutionary role of asymmetry in the human lung and to apply that knowledge towards targeted drug delivery. Now, understanding the physics of fluid flow and particle transport in the lung is required for answering questions like how do airborne diseases like COVID-19 infect our lung? How do atmospheric pollutants affect our health? And on a more constructive note, how can pulmonary drug delivery be optimized and customized for specific patients from an engineering perspective? Now, experimental or full-scale CFD studies are extremely difficult because of the complicated geometry of the airways and the varying range of length scales. Therefore, reduced order mathematical models are generally employed. I have listed a few of them over here, and the model that we use are based on the last one, that is a stochastic asymmetric multipath model. And to the best of our knowledge, there has been no systematic study of asymmetry in the airway branching that has been reported in literature. The main goal of my thesis is to bridge that gap. So now we will look at lung anatomy in brief. So our airways form a dichotomously branched structure as shown here. Each level of division is termed as a generation, and there are approximately 23 generations in the lung, in the human lung. Simple geometric models assume these bifurcations to be symmetric, but in reality they are asymmetric. However, a recent physical review letter showed that this asymmetry is not random. The degree of asymmetry remains more or less consistent across all generations. So if we look at the table above, the value of this degree of asymmetry for human beings is 0.326. We will revisit this value once again in the upcoming slides. So the main takeaway here is that there is an asymmetric manner in which airways branch, but there is a regularity in that asymmetry, which we use for building our geometric models. So we assume Hess-Murray law laminar flow as well as incompressible flow. And we define the flow dividing ratio R, which characterizes the asymmetry. And using these relations, daughter diameters are related to the parent diameters in using these expressions. So we start from the trachea, which is around 20 millimeters in diameter, and we keep determining the diameters of the subsequent generations until the diameter of any bronchiole becomes smaller than the cutoff diameter DC, which is the biological limit to how small a particular bronchiole can be. In order to make things more biologically realistic, we include stochasticity into our model. The variable R is treated as a Gaussian random variable with a 10% deviation around its mean value. So we perform Monte Carlo simulations of that. And the results which we present actually are the ensemble average of around 3000 realizations. The respiratory zone has alveoli attached to the ducts, and they become approximately symmetric. And other geometric parameters which are available in literature, we incorporate that into our model. For estimating the deposition efficiencies, we take different analytical as well as empirical models available in literature for different regions. So this is for oral breathing and nasal breathing, and for the main bronchioles, the deposition occurs through three mechanisms: impaction, sedimentation, and diffusion. These are the expressions of those three mechanisms. And in alveoli also, deposition occurs through mainly sedimentation and diffusion only, and these are the expressions for that. So using all this geometry and deposition models, we build a complicated model of the of airflow as well as particle deposition, and we validate that data against experimentally available data, and we can see a reasonably good fit here, and we proceed with using our model for estimating different lung performance parameters. So the first one of them is the number of terminal branches, which is directly correlated to the surface area available for gas exchange, then the fluid dynamic resistance offered to inhaled air, then the volume occupied by the entire bronchial tree, and the different depositions. We now look at the effects which asymmetry has on each of these parameters. So in the first figure, we look at the variation of surface area with the value of R, and we can see that the surface area is maximized for R equal to 0.5, which is symmetry. And with increasing asymmetry or decreasing R, this value decreases. Similarly, for volume as well as resistance to airflow, we are seeing which should be minimized. We can observe that these are minimized at R equal to 0.5, that is symmetry. So but in real lungs, there is a certain asymmetry, which we saw that R equal to 0.326. Now, that seems to hurt the optimal lung design if we take only these three parameters into account. So, in order to look at the complete story, we have to look at the particle filtration, which is served by the tracheobronchial deposition. So, basically, the particles get deposited in the upper airways and are unable to reach the deep lung. And this particle filtration is actually maximized at R value of uh, at, at an intermediate value of R. which turns out to be very close to the actual value that has been measured in human lungs. So using these results, we can explain that the asymmetry has evolved as a feature of the lung in order to maximize the filtration and maximize the protection against foreign particles, even at the expense of breathing efficiency. Then we move on to the second part of my work, where we are looking at targeted pulmonary drug delivery, which has its benefits of its own, like high efficacy and low side effects. And the entire class of entire the entire bunch of drugs which are administered in this way can be classified into two classes which target two different regions. One class targets the lung tissue as well, so they should be absorbed in the tracheobronchial region. They include bronchodilators for treatment of COPD, asthma, and so on. They relax the smooth muscles. And there is a second class of drugs which target to reach the deep lung, and their main goal is to get absorbed into the bloodstream and through circulation reach other organs of the body and work on them. So one common symptom which is seen in most lung diseases is bronchoconstriction, that is narrowing of the airways, and that is characterized by this parameter beta as shown here. So what we now do is we look at the effects of asymmetry, particle size, and bronchoconstriction on the regional deposition. So this figure shows the regional deposition versus the generation number n and the effect of asymmetry on it. We can see that with increasing asymmetry or decreasing R, the deposition in the upper airways decreases and that in the lower airways increases. Now we will look at the effects of particle size on regional deposition. We can observe a significant deposition in the upper airways only for the very small and the very large particle sizes, and for all the intermediate particle sizes, they penetrate deep into the lung. That is also evident from the overall deposition versus particle size, which shows a trough in between corresponding to those most penetrating particle sizes. Now we look at the effect of bronchoconstriction, which seems to increase the particle deposition in the upper airways and decrease that in the lower airways. The bronchoconstriction also increases the overall tracheobronchial deposition. However, the sensitivity is dependent on the value of R. Then we look at the variability in the regional deposition at each generation. So this figure shows the standard deviation of that regional deposition. We can see that for a fixed geometric variability, the deposition variability shows a minima at the generations 13 and 14. So that can be a sweet spot for minimizing intersubject variability while administering drugs through the inhalation route. Then we will look at the ACNR deposition, which is reduced by asymmetry, bearing further testimony to the fact that asymmetry increases protection against foreign particles and avoids them from reaching the deep lung. However, on the flip side, here the drug dosage requirements increase. Then we look at the variation of SNR deposition with particle sizes, and the two peaks over here correspond to the particle sizes which would have the maximum efficacy because they maximize the deposition in the SNR region. Then we look at the response to bronchoconstriction, which decreases the alveolar deposition, thus increasing drug dosage requirements as well. To quickly summarize everything, the human lung, which has a cutoff diameter of around 400 microns, for that, the particle filtration is maximized at R equal to 0.292. This is within 10% of the actual value measured in lungs, human lungs. So if we reduce the value of R from 0.5 to 0.326, we can see that this filtration efficiency increases by 4%, whereas the parameters which indicate breathing efficiency, they deviate from their optima by more than 10%. So counterintuitively enough, the lung has evolved in order to emphasize protection against foreign particles way more than maximizing breathing performance, because having a very efficient breathing has no meaning if the person keeps getting infected regularly and keeps falling sick. So this is how Mother Nature has incorporated asymmetry as a self-defensive mechanism. Then we saw the effects of asymmetry, particle size, and bronchoconstriction on the way in which regional deposition is distributed across the lung. And we also saw that with bronchoconstriction, the deposition in the upper regions increases and that in the deep lung decreases. So these results and these effects should serve as guiding principles while determining precise dosage of medications, as well as the choice and design of delivery devices like inhalers or nebulizers. So the first part of my work, which discussed the evolutionary role of asymmetry, has been submitted in scientific reports and is currently under the second stage of review. Another paper got recently published in Physics of Fluids. However, this paper is not related to my PhD. This is some work which I had done earlier. And among the future plans for my PhD, I intend to improve my model by incorporating mucus transport, virus kinetics, as well as immune response. I also intend to perform time evolving simulations by doing discrete event simulation on top of the Monte Carlo simulation that I'm already doing. And we have also started doing a detailed CFD study of lung bifurcations. One master student from our lab is also working on this project. So from this entire study, we will have thoroughly described the role of different parameters on the functional efficiency of a breathing lung. So that's all, and thank you.